Hello, welcome to a presentation about acute kidney injury, also known as AKI. This presentation has been developed as part of the Bachelor of Nursing degree at Swinburne University, Unit NUR 20005, Pathophysiology and Acute Nursing Care. Contributors to this presentation are Amy Coulston, Susan Hong, Ebony Mansa, Kanchan B. Tharpa, and myself, Asta Dressel-DeBrun.
Our case study is on BettyDavis, who is a 75-year-old female who is presented to the emergency department after a fall at her nursing home. The aged care staff has mentioned to the MS officers that the patient has become increasingly confused over the past 2 weeks and has been having dysuria, nocturia, and malodorous urine. Her past medical history includes type 2 diabetes mellitus, hypertension, hypercholesteremia, recurrent UTIs, or urinary tract infection, and functional decline. On examination, Mrs. Davis has a temperature of 38.4 degrees, heart rate of 124 beats per minute, breast rate of 24, blood pressure of 189/90, and oxygen saturations of 98%. Her blood glucose level is 12.2 millimoles per litre, and she has been complaining of lower abdominal and flank pain. A urine sample is collected and is positive for leukocytes, nitrates, protein, ketones, glucose, and blood. Blood tests show that the patient has a high white cell count and neutrophils, as well as a low glomerular filtration rate, or GFR.
The patient is presented with a past medical history of repeated urinary tract infections leading to acute kidney injury, and so pathophysiology of both urinary tract infections and acute kidney injury is necessary. The following 3 slides describes the pathophysiology of urinary tract infections. Pyelonephritis, causing inflammation to the kidney and its structures, commonly results from an infection of the lower urinary tract that ascends to the kidneys, and sometimes infection may be spread from elsewhere in the body to the kidneys. Symptoms of pyelonephritis are fevers, chills, flank pain, nausea, vomiting, and urinary frequency. Pyelonephritis can be acute or chronic, and if not treated appropriately, can lead to kidney damage and decreased kidney function. Cystitis causes inflammation to the bladder and is caused by a bacterial infection, calculus, or abnormal growths. Symptoms include pelvic pain, pain on urination, urinary frequency, and hematuria. If not treated, cystitis can cause upper urinary tract infections such as pyelonephritis as the bacteria ascends through the urinary system. Urethritis is inflammation of the urethra caused by a bacterial infection as well as sexually transmitted infections such as gonorrhea and chlamydia. Symptoms include yellow or green discharge from the urethra, dysuria, urethral constriction, pain on urination, and hematuria. If left untreated, urethral constriction can lead to stagnant urine in the bladder and is an ideal environment for bacterial growth and ascension to the kidneys, causing kidney damage. Complicated UTIs are infections that are complicated by a variety of factors, such as anatomical structures, including the length of the female urinary tract, anatomical abnormalities such as renal calculi or hydronephrosis, comorbidities such as treatments causing immunosuppression, or a past medical history of diabetes, and insertion of instrumental interventions such as urinary catheters. Complicated urinary tract infections are not easily treated with antibiotics and can cause further damage to the host, such as sepsis. Uncomplicated infections are caused by a simple ascension of bacteria, most commonly Escherichia coli, commonly known as E. coli, entering the urinary tract and combating host immunity. These infections are usually easily treated with antibiotics. Multiple bacteria that cause urinary tract infections. Pathogens that are both gram-negative and gram-positive. However, infection from gram-negative bacteria is more prevalent in causing infection. Additionally, some fungus and viruses are responsible for infections. The most common bacteria resulting in urinary tract infection, however, is E. coli. Uropathogenic E. coli is the stream of E. coli that causes infection to the urinary system once it survived the host's immune response and begun colonizing the site. E. coli is a bacteria of the digestive tract. It is a gram-negative pathogen and has high rates of antimicrobial resistance in neuropathogenic E. coli, leading to increased hospital cost, morbidity and mortality. E. coli accounts for most urinary tract infections. However, some pathogens of note in causation of urinary tract infections are Klebsiella, Proteus, Pseudomonas, Enterobacter, and in the gram-negative group, and Staphylococci, Enterococci, Group B Streptococci, and Corynebacterium urulitium in gram-positive. As outlined, there are multiple bacteria that cause urinary tract infections, so we will focus on the most prevalent, E. coli, as it has many streams and lives in the digestive tract. The uropathogenic E. coli stream is highly virulent and therefore has a high prevalence in urinary tract invasion. Particularly important in its virulence is the fimbriae, which are nanofilaments able to extend from the bacterial cell for micrometers, enabling attachment to host cells, bacterial colonization, and genetic material exchange. A critical factor in the enablement of bacterial binding to superficial uroepithelial cells is type 1 fimbriae presence, as it contains the mannose receptor uroplacin. As bacteria binding occurs, the host cell sheds, enabling bacteria infiltration deep into the cell layers of the bladder wall.
As the infection ascends from the bladder through the ureters and reaches the kidney, it is termed pyelonephritis. It invades the renal pelvis, spreading to the calyces and medullary tissue. Spencer, Swarter, Becknell, Watson and Haynes, in their article on the innate immune response during urinary tract infection and pyelonephritis, published in 2014, discuss how, coupled with the progression of the infection, is the innate immune response, which includes phagocytes, inflammatory mediators and exudates, and how they move from the blood into the affected area, and this influx impedes tubule function. As the tubules become impeded, this is known as tubulointerstitial nephritis. Joyce, Glasner, Ranganathan and Swaitaker-Urban, in their article on tubulointerstitial nephritis, Diagnosis, Treatment and Monitoring, published in 2016, outlined how the inflammatory mediators infiltrate the medullary tissue around the tubules, causing edema. This places pressure on and injures the surrounding structures of the capillary bed and the nephron tubule. Bullock and Hales, in the textbook Principles of Pathophysiology, published in 2018, discussed how hindering the blood supply to the tubules inhibits many functions, including nutrient and oxygen exchange, reabsorption and excretion of electrolytes, causing electrolyte imbalances, and the retention of waste products in the plasma that are normally excreted in urine, like creatinine. If the infection is still not treated, it continues to ascend in the renal tract, reaching the renal cortex and the glomeruli of the nephrons. As the glomeruli become involved, this is known as glomerulonephritis. Osterman and Lau, in their article on Pathophysiology of AKI, published in 2017, discussed how the inflammatory response in the glomerulus increases blood flow and capillary permeability in the capillary bed, increasing glomeruli hydrostatic pressure, causing the filtration membrane to become excessively leaky to blood cells and some large proteins, allowing their movement into the filtrate, and as they cannot be reabsorbed in the tubules, they are then excreted in the urine. This is known as hematuria and proteinuria. According to Bullock and Hales 2018, as the injury to the glomerulus progresses, it results in less efficiency in the forming of filtrate and a resulting fall in glomerular filtration rate, causing urine volume to fall, oliguria, and a subsequent rise in blood volume and nitrogenous wastes, azotemia. Bullock and Hales 2018 go on to talk about how normal nephron function can be restored if the infection is addressed. However, if the inflammatory process intensifies or persists, the glomerulus may die. Consequently, the rest of the nephron dies as the blood supply to the rest of the nephron is interrupted. If this is a cumulative effect and large portions of nephrons die, the result will be renal failure. The diagnostic tool, adapted by the Acute Kidney Injury Network and accessed in a journal article by Macris and Spinell titled Acute Kidney Injury, Definition, Pathophysiology and Clinical Phenotypes, published in 2016, shows the stages of a kidney disease and how these stages are defined against measurements of urine output, serum creatinine and glomerular filtration rates. RIFLE stands for risk, injury, failure, loss, and end-stage kidney disease.
Early detection of AKI is paramount for Mrs. Davis. This will allow her to receive immediate care, alleviate symptoms, and reduce the risk of kidney damage. In order for Mrs. Davis to receive holistic care, a number of interventions need to be implemented. According to an article by Halsey and Davies, 2015, using the method of 3 R's, recognition, response, and referral, will increase the chances of positive outcomes for patients like Mrs. Davis and her current condition. The 3 R's can be successfully achieved by completing diagnostic tests, medical management, nursing care, and patient education.
As Mrs. Davis has presented with an acute kidney injury due to undiagnosed urinary tract infection, the nursing interventions include basic observations such as blood pressure, including a postural blood pressure, as she could have postural hypertension which could cause her to fall. These also include a heart rate, respiratory rate, oxygen saturations, temperature, and Glasgow Coma scale as a baseline to assess whether she is deteriorating, according to Bevan M. 2016. According to Bevan 2016, further investigations include blood test, urine analysis, urine culture, and fluid balance charts. Blood tests include FBE, UEC, LFT, CRP, GFR, urea, lactate, and creatine, which show if there are any abnormalities in the blood, such as electrolyte disturbances, kidney function, and if there is any infection present, according to Larangia Reginato and Da Silva Margot 2018. In Pesalda and Carmody 2016, it states that glomerular filtration rate, or GFR, measures the kidney function and shows the amount of plasma being filtered across the glomerule every minute. The normal GFR level for adults is approximately 120 mL per minute per 1.73 meters squared. When less plasma is being filtered, it can mean an increase in electrolytes and fluid abnormalities. The GFR level may also be decreased due to elderly age. If Mrs. Davis is continent and compliant, a urine analysis should be collected and analysed for traces of blood protein, leukocytes, and nitrates, which indicates if there is an infection, because normal urine doesn't have these in it, which is stated in Nakani and al. 2017. A urine analysis should be undertaken prior to the sample being sent, as it is a fast and effective test that looks for any infection in the kidneys, as clinically governed by the Australian Commission on Safety and Quality in Health Care, Standard 1, 2017.
Medical management. Kudikas, Staten and Houston 2017 described that in medical situations such as this, the main aim would be to restore medical balance and prevent complications so that the kidneys can repair themselves and return to normal function. In an article by Forney et al. 2016, measures such as avoiding hypoglycemia and nephrotoxins while using strict therapeutic drug monitoring were explored. Treating and eliminating the underlying cause of Mrs. Davis's AKI were multifaceted. Antibiotics targeting the infections caused by her underlying UTI was prescribed, along with fluid replacement therapy as a result from electrolyte changes shown in her blood biochemistry. In a journal that focuses on the nutritional considerations with patients with AKI, Maffrey and Williams 2016 highlight the importance of ongoing diagnostic review throughout a course of treatment and during patient recovery. This will allow Mrs. Davis's medical team to assess when kidney function recovers. By reversing the known cause of her acute kidney injury in a timely manner, it is anticipated that full recovery with no ongoing effects will occur. Nursing care. Liaising with Mrs. Davis's medical team and allied personnel will allow for her to receive every opportunity to achieve positive health outcomes. Daily monitoring of Mrs. Davis's fluid balance is vital, as we'll be able to see when urine output falls below optimal patient level. This could indicate the severity of the illness and have an effect on her hemodynamic stability. A daily weighing regime should also be commenced to ensure early detection of additional fluid loss. By assessing her vitals hourly and her response to treatment, particularly looking for signs of difficulty in breathing and edema, we'll be able to recognise deterioration and be able to respond appropriately. Because of her current condition, Mrs. Davis is at a higher risk of infection and her skin integrity is compromised. Using an asepsis skincare technique should therefore always be used. By providing Mrs. Davis with physical, psychological and emotional support, we will ensure that all areas of individualised holistic care is given to her. Patient education. Mrs. Davis or a family member will need education on the ability to be able to identify complications of fluid volume excess, such as edema and increase in weight. This is so a correction of medical management can be made. While she's in hospital, a nutritionist will also be able to educate her on how to achieve adequate nutritional support, as this is considered to be a key element in an overall therapeutic strategy of AKI patients according to Picadori, Regalisti and Cabassi 2009. Educating Mrs. Davis of identifying the causes and signs and symptoms of UTI infections reduces the opportunity for an infection to further manifest into the kidneys. It is also equally important for Mrs. Davis to have an understanding of the importance of seeking help in a timely manner. Education on preventative measures will also be discussed. These include being aware of the medications she is taking and the effects they may have on kidney health, keeping hydrated, monitoring her blood pressure, good personal hygiene, and having a focus on the importance of compliance with her diabetes management plan. Mrs. Davis will also require follow-up tests and assessments, looking at kidney functioning post-discharge from hospital, as she is at risk of recurring UTIs.
Now I'm going to explain about potential complication of acute kidney injury. Before explaining about the potential complication, we need to know about the normal functions of the kidney, and we can know about the complication in those functions. So the first function is to maintain water hemostasis or maintain normal blood volume. If this function is impaired and less production of urine, then this leads to volume overload, which can give symptoms like edema, dyspnea. It can give significant downstream pathologic consequences like heart failure, pulmonary edema leading hypervolemia. Kidney also maintain electrolyte homeostasis. It can impair function and leads to hypertension, where there is increase in sodium retention, hyperkalemia, hyperphosphatemia. It varies from different conditions and patient to patient, which shows typically asymptomatic. It gives life-threatening consequences like hypertensive emergency, arrhythmias, and sudden cardiac death. Kidney also maintain acid-base balance by regenerating bicarbonate in proximal tubule and excreting hydrogen ion in the distal tubule. If this function is impaired, then it can lead to consequences in metabolic acidosis. It is asymptomatic, but if we worsen, then it can develop dyspnea, where respiratory rate increase due to the fall in pH. If the pH is less than 7.20, then it can lead to different consequences like hypotension, arrhythmia, non-responsive by fall in blood pressure. Kidney also eliminates nitrogenous waste product as the urea. If there is a rise in level of urea, then it can give symptoms like fatigue, nausea, poor appetite, confusion. It can lead to two specific clinical consequences like encephalopathy and pericarditis. Encephalopathy can be manifested by confusion, drowsiness, disorientation, slurred speech, and impaired memory. Next, uremic pericarditis can be manifested as position of chest pain, ECG change, and in some patients it can be pericardial effusion. Another function is to eliminate medication and their metabolism. Kidney if this function is impaired, it can lead to toxic drugs levels that can give various symptoms and various consequences depending on types of medications. The last, but the not least, complication is sepsis, renal failure, and death. It is a life-threatening symptoms that cause with organs in dysfunction and lead to infection. There will be complete loss of glomerular and tubular function, progressing from anuric or oliguric phase through diuretic phase, which leads to chronic renal failure and cause acidosis, potassium intoxication, pulmonary edema, or infection. It may lead in death.